Hello and welcome to another episode of In Good Health with McLaren Macomb. I'm Toya Hankins. Today we're going to be talking with Dr. Kirk Garcia-Rios about the benefits of seeing your doctor on a regular basis. And then we have some exciting news about a new big project at McLaren Macomb. First, we're here to talk to Dr. Nikesh Ardeshna about epilepsy. Good afternoon, Dr. Ardeshna.
Good afternoon, Toya, and thank you for having me.
Welcome to In Good Health.
A pleasure to be here.
Thank you so much. I'm really excited to talk with you today about epilepsy. You're an epileptologist.
Yes.
Can you tell me what that is?
So an epileptologist is a neurologist that specializes in the treatment of seizures and epilepsy. Epilepsy is recurrent seizures. So basically I've had additional training in an epilepsy fellowship, which allows us to diagnose and manage seizures with the highest standard of care.
Okay. So where does the seizure live in the body? Like, what's the origin of it? Is it the brain or another organ that a seizure comes from?
So you're correct. So a seizure basically starts in the brain, and all seizures start there. It's an electrical phenomenon, so it's due to an electrical abnormality in the brain, but it can have many different causes, all the way from a prior head injury, to a stroke, to a brain bleed, to a brain tumor, to Alzheimer's disease. And actually 33% of patients who have epilepsy or seizures don't have a known cause.
Okay, so it's not genetic in nature.
It can be, so there are certain portions which are, but what you said is actually very important, because a significant portion of epilepsy does not have to be genetic. So anyone could actually have their first seizure at any age. There does not even have to be a family history or a risk factor.
Wow. Okay, so now no risk factors. So not even in the brain. Like if someone has some type of abnormality or are born with some form of disability or what have you, maybe not disability, but some type of abnormality in the brain, that wouldn't give them a predisposition for it? Or
no, that actually could. You are correct. So there are certain developmental abnormalities of the brain that does lead to a higher incidence or higher likelihood to develop epilepsy at any point in the lifetime. But if we took, say, 100 patients in this room who have epilepsy and seizures, and you and I kind of took a tally of them, 1/3 of them, we wouldn't find a specific cause.
I see. Okay.
And that's what makes my job even a little more difficult, let alone recognizing these. Yeah.
So now, what can a person do to avoid, prevent, or safeguard themselves in general?
So epilepsy and seizures, you can't necessarily prevent them. If, God forbid, you or I are going to develop them at some point, what's going to happen is going to happen, and some of that is part of the electrical workup of the brain. But you had asked, what could you do to minimize, if one occurs, any risk of injury or consequence? So we do have, we teach our patients when they come in, or make them aware about first aid for seizures. So in that sense, if someone is seizing here, to minimize their risk of injury, what we do is we try to lower them to the floor, turn them to their side, ideally their left side. We don't hold them or put anything in their mouth, because that could lead to injury either to the patient or to one of us who's trying to help.
I think that's what we all understood. I don't know how it got out there, but I remember a time in life where there was a story that you put a spoon in the person's mouth, or
that is correct, and that is still done, as much as I hate to say it, in places. Unfortunately, it's not the right thing to do. But of course, part of my job, and now that I've been here with you, both of us together, as well as other healthcare providers, our goal is to increase awareness of epilepsy and how to provide treatment for epilepsy in that emergency circumstance, the first aid. So yes, the basic is try to ease the patient to the ground if possible, or to a chair, so that we minimize the risk of a fall, get any hazardous objects out of the way, don't hold them or don't put anything in their mouth, because of, again, the risk of injury both to them as well as to us who may be trying to help. And then you had asked, let's say I do have epilepsy or seizures, what can I do to the best of my ability to prevent it, to avoid a breakthrough seizure, as we call it? Okay. So the answer there is, obviously, the primary treatment for epilepsy is what we call anti-seizure medication. So one is taking the medication as prescribed, being compliant, and then ensuring that as much as possible, an individual gets enough sleep, does not miss meals, minimizes stress, and infection is treated as promptly as possible. Because it's really those things, along with others, but those big four things, that even in someone who is taking their medications faithfully, that can still trigger a breakthrough seizure.
So I've witnessed a person having a seizure.
Okay.
Is it possible to have seizures that are not epileptic in nature, or do they go together always?
You are correct. So there is a type of seizure, which is what is actually referred to as a non-epileptic seizure. That's how I would tell patients about it. It looks externally like an epileptic seizure, somewhat like as you're describing, but this is not caused by an electrical abnormality in the brain.
I'm aware that you have new equipment and technology that you're using to help people who are dealing with this. Can you tell us a little bit about it?
Sure. So McLaren Macomb, as part of McLaren Health System, has started a new subspecialty service line as part of their neurology service line, and that is basically specialized diagnostic and management for epilepsy and seizure patients. So that includes consultation with an epileptologist such as myself. We have outpatient testing available, as well as the hallmark of the program is actually an Epilepsy Monitoring Unit, or we refer to that as an EMU, and it's a 2-bed unit inpatient that is actually dedicated for epilepsy patients. It contains specialized equipment such as 24-hour video monitoring as well as audio monitoring. So in this case, patients are brought in on an elective basis or pre-scheduled basis for a multiple night stay. And what we do there is just as we talked about with the EEG, but this is a much longer and more specialized EEG with audio and video. We record their EEG for multiple days, and in that case, our goal there is to diagnose seizures, determine the type of seizures, sometimes clarify the diagnosis when it's unclear, and then determine the optimal management plan. And in that unit, we have, as part of that, McLaren Macomb has specialized EEG technologists that monitor the patient 24/7. So I am one of that team of healthcare providers.
Okay.
And the purpose of that unit, the technology has been available for years. We are fortunate now locally here in Macomb County that McLaren Health now has it, and the first place that McLaren has it is McLaren Macomb, and they've designated that as the system's epilepsy hub. So when these patients come in, what we do is we actually try and provoke and record their seizures under these circumstances to help us, one, verify the diagnosis, clarify it, determine where their seizures are coming from, the type of seizure like you alluded to, and then determine their optimal management.
Wow, that's amazing. So in provoking it,
Yes.
Is it activity that you will have them do? Will you put them under stress, or what does that look like?
Yes, so it's actually, there's limited things we can do. Sometimes we wish we could do more, but again, safety is the first goal. What we do is when the patients come in, we slowly take them off their anti-seizure medications.
Okay.
And then, as you said, there are certain stressors, such as we do something called photic stimulation, which is flashing lights. Sometimes we sleep deprive them, which is a stressor. And it's a combination of these that we hope to record a seizure by, because it makes a seizure more likely to occur.
A person who has epilepsy, can they feel when a seizure is coming on? I'm wondering if it impedes the quality of their life in any way.
So you made an excellent point. So there's two issues there. So some patients who have seizures or epilepsy do have what they refer to as a warning before it. So they may be able to feel something, and that's what we refer to as an aura, okay? But not everyone does. So again, just like every individual is different, to me, every patient with epilepsy is different, okay? And we have to make a unique management plan for them. And then you had asked about
quality of life.
the quality of life. And so with that, there's really one thing that in my opinion, is the underlying treatment principle. So as an epileptologist, my goal for an individual with epilepsy or seizures is to get them to seizure freedom, be seizure free, and have no side effects.
I like
and
that,
to do
seizure
that,
freedom. Nice tagline
as soon
there.
as possible. And actually, it is actually the Mentera of the Epilepsy Foundation of the United States. That is the goal. And with that, to your point, so we want to achieve seizure freedom and have the patient have no side effects as soon as possible. The reason we want to be aggressive in this is because you want to prevent the long-term consequences of seizures, like memory loss or injuries. And then the key is that aggressive treatment allows them to have a quality and a productive life. So in fact, in my opinion, individuals with epilepsy can live a quality and productive life. In fact, that's the goal that we want them to have and have them achieve that as soon as possible. If we can't make them seizure free, still we want to control seizures as aggressively as possible to maintain that quality and productivity. And in fact, there is studies that show that the more aggressively you control seizures and the sooner you do, the better the quality and the productivity of that individual.
So you mentioned, we talked about how it's sometimes difficult to diagnose epilepsy and seizures.
Yes.
And why is that? You know, I know that in the public, from a public perspective, we are familiar with the grand mal seizure type of symptoms where the body shakes a lot and maybe the person loses consciousness or what have you. But what other symptoms should we be aware of?
So Toya, you are correct. Epilepsy is still a clinical diagnosis. And as we said, sometimes it's difficult to make and it's delayed because what we view as the most common, what the public views as the most common picture of a seizure is, as you said, an individual who falls, their body stiffens, they lose consciousness, they shake, and afterwards they're sleepy or lethargic. But there are actually many different types of seizures, some which are even more common than that. And that includes such things as confusion, memory loss, abnormal movements of the lips or the hands. We often call them picking movements or automatisms, changes in speech, or even hallucinations, or some combination of all these.
Wow.
Okay?
And would they occur at the same time? Is it something that you
So they
see a
would-
pattern of these things?
So they would occur in succession, you know, a
Okay.
couple of them. But this is actually, because it is often difficult to see these things or recognize them, in particular, they're often attributed, family members often attribute this, say, this is something else going on, it can't be this. So they're given a different diagnosis. Or because they're so subtle, you know, somewhat small, the diagnosis is delayed. So part of, as we said, why has this been going on for so long? Why is there a delay in diagnosis? Is this? And part of my job in increasing awareness is to actually increase the awareness of these other symptoms of seizures, which are equally as common, but this is how they can present.
Very good. Thank you.
Thank you, Toya.
Learn more at mclaren.org/Macomb Epilepsy.
And now, more about our new big project at McLaren Macomb.
I'd like to welcome all our guests and thank them for spending this evening with us tonight. We are so excited to be here today and celebrate the construction of our Northwest Tower and much-needed Wayne and Joan Weber Emergency and Trauma Center.
I got to tell you, I'm excited for many reasons. It's a statement, it's a testament to the fact that they do care and they are committed to the health care of the residents here in Macomb County. And I know there are several people, and I'm just going to mention two, that actually would like to be here and aren't here. And I say that because you had already mentioned Wayne and Joan Weber, incredible folks within our community that are very giving, very kind, and very compassionate. And their generosity is what's going to make this or help this become a reality. The other person is a guy that was very committed to this hospital, and I know that he would love to be here. I know that his son is here, Mr. Ted Wabi, who is not with us today, but I know he's looking down and very proud and impressed about what's happening at this hospital facility.
So tonight we're here to celebrate the groundbreaking of a new facility, a story that I've been trying to tell as avidly and consistently as I possibly could over the last 3 years. What you might not know about our hospital, we train more than 100 residents and fellows in any given year. And so the building we're going to start building here is a 5-story building with a basement. In the basement, the physicians dedicated their money because they wanted me to build a brand new graduate medical education center. So we attract physicians from all over the country, all over the world, who want to come here and train at our hospital. In order to continue to attract the best and brightest, we have to have the right facilities and equipment. And then really the main event. If I could only have one thing out of this entire building, it's the Wayne and Joan Weber Emergency and Trauma Center. When this new center is done, we're going to have a brand new behavioral health unit built within the emergency center designed to inpatient behavioral health standards so that the patients and the staff can be safe in that environment and we can treat them appropriately for while we're waiting to get them to the next step of their care. The team from McLaren, we come to work every day to deliver the absolute best patient care. That's what we all want to do, nothing less. This new facility is going to provide the perfect setting for us to do that. So thank you all very much, and I want to have the shovel guests come up and let's turn some soil.
Learn more about McLaren Macomb's trauma capabilities at mclaren.org/Macomb Trauma.
And now we're here with Dr. Garcia-Rios. Good afternoon, Dr. Garcia-Rios.
Hello.
Is it okay if I call you Dr. G?
You can call me Dr. G.
Okay, wonderful. Welcome to In Good Health with McLaren Macomb.
Well, thank you. I'm glad to be here.
So you're a family medicine doctor.
Absolutely.
Sounds like that covers an awful lot.
It does.
Can you tell us a little bit about it?
Well, family practice is basically that. We do a little bit of this, we do a little bit of that. Cover all specialties. As far as what I do, you manage children. We do peds. I do peds. Through adult medicine, geriatrics, we do women's health. The nice thing about family practice is that we're kind of the gatekeepers. Mm-hmm. So somebody comes in, and if it's something that maybe they're not responding to treatments, specifically what it might be, then we have the opportunity to refer out to specialists. So if we have somebody that comes in and I do an EKG, and there's something not right on the EKG, they might need further testing, might refer them to a cardiologist. Mm-hmm. Same thing with get somebody that comes in and they have an orthopedic problem, they have a fracture. We fix them up, splint them, and then we'll refer them so that they can get properly treated, whether they need surgery or anything else.
Okay, so you're the first line of defense in most cases?
Absolutely.
Okay.
We're the first ones that people come and see.
Okay. And so technically, your office could see someone from birth to the end of life. Is that correct?
The great thing about family practice is, especially in my case, since I'm new, you build a practice. You have families that come in. You see the husbands, you see the wives, you see the kids. Mm-hmm. You watch them grow, and you kind of grow with them. So it's kind of like a big family. Mm-hmm. So and then as time goes and as you see them, it's almost like making friends. You know who they are. You know what their issues are, and you understand them better each time they come in to see you. Mm-hmm. So you have a very personal a
great relationship. Yeah.
Absolutely.
Mm-hmm. That's awesome. Now, this might be a difficult question because you deal with such a wide range of people and patients. Do you see things commonly in age groups of people? So do you treat children for any specific things more frequently than another issue, or senior citizens for something more than something else?
That's a really good question. And I'm sure you're well aware of this. You see it in the news, quite frankly, when you go out to eat or you go to a grocery store. Mm-hmm. Obesity, is the big problem. And that's one of the biggest challenges. And you see it across the board. You know, I got young kids that weigh more than I do. And, you know, how do they get that way? You know, trying to stop in the beginning, but it's something you're seeing all throughout all age groups. So it becomes a challenge.
Wow, and is that something that you deal with in office as well?
Yes.
You help to, do you do nutrition management and those sort of things? Or-
Absolutely.
Okay.
Nutrition management, you know, obviously my big thing is lifestyle changes. Lifestyle changes are the most important because you're not going to be successful unless you focus on lifestyle. And, you know, when we talk about diets, I hate the word diet because, quite frankly, there's no such thing. It's a lifestyle.
Right.
So, you know, you watch what you eat, and moderation is the key. Too much of a good thing is bad, and you don't get enough exercise, and sets up the perfect recipe for, well, you know, obesity and health problems down the road.
Is there a frequency that makes sense? Like, should people see you once a year, or how often should they come in?
It's another good question. So, part of being a family doctor is being a preventative health doctor.
Okay.
So, if you can prevent the disease, that's the most important goal of what I do. And that's the kind of doctor I hate prescribing medicines. So, if we can get to the point where somebody becomes a diabetic or somebody has high cholesterol or high blood pressure, that's great. So there are things that we do, such as we do physicals. It's recommended that, you know, a person comes in at least once a year for that, you know, depending on their age group, because there's different periods in life where you start screening for certain things. Now they're screening for things like hypertension very early on in life, start screening for cholesterol, you know, later on in life, and then so forth. And then as we get older, you know, like such as for women, for example, you know, when you turn 40, you know, most doctors do mammograms, you know, do mammograms. And then, you know, as we get older, and those are screening tools, just because the risks of certain things do go up with age, you know, such as a colonoscopy at the age of 50. Just being sure that there's nothing there that raises any eyebrows that could be a problem. So if we identify those things, that, you know, obviously that keeps the person in a state of mind of good health. So I would at least recommend every year a person should come in for a physical.
Okay. So should a person come in and see their family doctor only when they're not feeling well, or is there a way to come in to be proactive and preventative, a frequency that would lend itself toward that?
That's a very good question. So, you know, the thing is that when it comes to people and patients, you know your body better than anybody else. So, you know, if you feel that there's something not right, of course come to the doctor. You know, we have a lot of people that come in, you know, they get a little sore throat or something like that. It started, you know, a day, you know, should they come in for that? Probably viral. But, you know, if they feel like there's something wrong, then yes, they should come in. I don't think there's no such thing as coming to the doctor as many times as you need it. And I think it just goes back on the patient. How do you feel? Do you feel like you need to be treated or seen?
Do you find that you have a greater frequency of patients coming in different times of year because of allergy season or cold season or things of that nature?
Oh, absolutely. Especially the autumn, winter, early spring. You know, flu season's big. It's been a bad year this year. Had a lot of people come in, and it seems to be a trend every single year. Very similar things. You know, people come in, you know, with colds and flu, seeing quite a bit of flu, sinus infections. And that seems to be a pattern. You know, you can see all that stuff throughout the year, but it seems to decrease during the summertime. You know, and then when, you know, spring comes, you know, I get a lot of kids that come in wanting sports physicals because they're going to get ready to play sports. So it's different times of the year that people come in. You know, and then as far as physicals go, that seems to be throughout the year.
Okay. Is it helpful from the doctor perspective to have patients coming in on a regular basis annually in their overall health picture?
Absolutely. It's continuity of care. You have a person that comes in, now we do a physical on them. They're 40. I'll use a lady, for example. We do all their preventative blood work. We check their things like their cholesterol, their thyroid, screening them for diabetes, checking their blood pressure, ordering all the necessary preventative tests. So, you know, everything comes back, we review it, cholesterol slightly abnormal. So obviously when something comes back, there's always some kind of follow-up. What can we do at that time to make that person better? We're going to discuss things like lifestyle changes, what can we do about diets, calorie restrictions, and maybe have them come back in 6 months to check that. So it's all about continuity of care, because if something's wrong, we want to know if they're making improvements so that we can fix the condition, versus if the person doesn't come back. They come back, several years later, we know nothing what happened between that point in time. And, things could have changed. Maybe the person's health went downhill, and, if we don't have that continuity of care, then it would be very, very difficult to treat the patient.
Okay, and how many ailments do you see that go undetected? Where people don't have actual physical symptoms, but then upon doing a checkup, you find something. Does that happen frequently?
It happens, absolutely. Good example is, I have a patient that comes in and sees me for the first time. We do a physical. We do their blood work, their fasting blood work, and they have a fasting blood sugar of 300. Yet they don't have any symptoms, they feel fine. Person's a diabetic.
Wow.
Absolutely. So that's actually more common than people think.
Okay. So the key here is set a regular appointment, make sure you don't miss your appointments, and pay attention to your body.
Absolutely.
Listen to your body.
Absolutely.
Any other advice you'd give people
I tell
to
people,
maintain good health?
Especially in our society, there's so many good places to eat. There's so much processed food out there. And, I'm very, very big, especially when it comes to peds. And I counsel patients, because habits are formed very early on in life, such as diet. And, if you eat processed foods and you eat poorly, those are habits that stick with you throughout life. As far as part of the battle against obesity, targeting that very early on in life so that you can correct those behavioral patterns now, versus when you do become an adolescent or you become an adult. And now you have issues where you're overweight as a child, you're overweight as an adult. Now you're higher risk of developing hypertension and diabetes, and higher risk of developing heart disease later on in life. So, and being active. Being active is so crucial. And we are somewhat of a sedentary society. And it's not just for people who don't exercise. There's a lot of people who work long hours, but they have desk jobs. It's like, how do you make the time to go exercise or be active? And those are all risk factors, and what can be done to correct those things. So, that's one thing I counsel people. What are some things that you can do to make yourself more active, and what are things that you can do to watch your diet, as far as portions and calories, and as far as what you're consuming, because those all make a big difference as far as your overall health in the long run.
Thank you so much for your time, Dr. G.
Well, thank you very, very much for having me here.
Thanks
It was
for
a
being here.
pleasure.
Make an appointment at mclaren.org/Macomb appointments.
Thank you for joining us for another episode of In Good Health with McLaren Macomb. We'll see you next time.
To watch this episode again, visit mclaren.org/Macomb blog.